Good morning and happy Cinco de Mayo. I'm Dr. David Wild, Vice President of Performance Improvement, in this morning for Dr. Steve Stites, our Chief Medical Officer. We're coming to you from the Dolph Simons Jr. Family Broadcast Studio again today. Our guest this morning, Dr. Stephen Simpson, a pulmonary, critical care, and sleep medicine expert, as well as the president of CHEST, the American College of Chest Physicians. And we're going to spend the morning talking about COVID-19 sepsis. But first, as always, Dr. Dana Hawkinson, our Medical Director of Infection Prevention and Control, is here with our numbers. Dana, how's it look this morning?
Still not where we'd like it. 22 active infections, with 7 of those in the ICU and 5 on the ventilator. We still have 10 in that recovery period as well. So the active infections are still running much higher than we would like. We know that cases overall in the United States are continuing to trend down. The rolling 7-day average continues to trend down. I think right now we have seen really an increase in the Kansas City area rolling 7-day average over the last week. I think it's about plateaued right now. So we'll see how these next few days come out as far as new cases. And of course, more importantly, hospitalizations. And then Hays has 1 active infection as well. So.
And you know, we've mentioned the collaboration among the community of healthcare delivery systems across our community here over the last year. And just yesterday, we had our weekly conversation with the chief medical officers from the other facilities in town, and we are definitely not alone.
No.
I think all but 2, maybe 3 of the hospitals in town have seen an increase over the past week or 2. And actually, our 120% increase in our 7-day rolling average over the last week or 2 is not actually all that unique. In fact, there was one of our partner facilities here in town has jumped from 2 to over 30 acute patients in the last few days. So while it's not everywhere and it's not overwhelming, that's not necessarily the message here.
No.
It is different than a week ago or a month ago, and it's not just here. So I'm sure we'll talk more about that as the morning goes on. Before we jump farther into conversation today, are there any reporter questions on the line? Does not sound like it. So we'll turn right away to Dr. Simpson. Welcome. Thanks for joining us.
Thank you, David. I'm happy to be here.
Before we talk about COVID-19 sepsis, maybe let's actually take a moment to explain what sepsis is.
That's great way to start there, because that's what I was going to do anyway. Sepsis begins with infection, always begins with infection, any kind of infection. Bacterial infection, fungal infection, even viral infection. Sepsis is defined as a life-threatening organ failure due to a dysregulated host response to infection. That's kind of a mouthful. What that really means is that your immune system and other things that react to infections in your body have sort of gone off the rails, and what they're doing is causing damage to your own organs. In a certain sense, sepsis is your body attacking itself. It's actually not attacking itself. It's hurting itself as it tries to attack the bacteria or virus or fungus that's attacking you. So COVID sepsis just happens to be a septic incident. It's when your body is responding to COVID, or to SARS-CoV-2, I should say. It's when your body is responding to that virus in such a way that you cause damage to various organs in your body. And it's actually quite common.
The next question, because we often hear sepsis and shock used in the same conversation. What is shock, and is it the same thing as sepsis?
Yeah, that's a wonderful question. I love getting that question. So, no, shock and sepsis are not synonymous, although there is a condition called septic shock. So let's talk about shock for a moment. Shock basically is the result of when various tissues or organs in your body are getting an inadequate supply of oxygen, one way or another. They're either your heart's not pumping it enough, your blood's not carrying enough, your lungs aren't working well enough to put the oxygen in, Or sometimes it's directly as a result of infection that your cells are there and they're getting lots of oxygen, they just can't use it. Their mitochondria and the mechanisms of a cell that use oxygen just aren't working. But shock is the end result of that. Now, it can cause a number of different things, but generally we consider very low blood pressure to be the hallmark of shock. And of course, there goes Dr. Simpson's telephone in the middle of the broadcast, and I'm sorry, I forgot to turn it off.
Fire questions about shock right
Yeah, that's it. From all over the world,
That's right.
I'm sure. But generally, when a person is in shock, what they have is low blood pressure that won't respond to us giving them some IV fluids. And most often they also have an increase in something called lactic acid. Lactic acid is a product that the cells of your body make when they are not having an adequate oxygen supply, and they have to keep living and they have to keep doing what they're doing, but they have to switch over to mechanisms that aren't using oxygen. You can only do that for a few minutes. In fact, if you're deprived of oxygen, you can only do that for about 4 minutes before you die. But lactic acid is produced, and for those of you in the audience, probably a good way to think of this is climb 2 or 3 flights of stairs in a row and feel what you feel in your legs, and that actually is lactic acid. That's the burning sensation that's there. In sepsis and in other forms of shock, we're producing that all over our body and having a hard time getting rid of it.
And before we talk specifically about COVID-19 and sepsis, how big a problem is sepsis? Is it something that we see frequently, or when I say we, you and your colleagues in our ICUs, for example?
Well, most assuredly in our ICUs we do, and in fact sepsis is the single most common cause of needing to be in an ICU. Across the nation, there are over 1.7 million cases of sepsis every year, and approximately 350,000 people die every single year from sepsis, and that was before COVID, and it has continued through COVID, sepsis of various causes.
You know, as we begin the sort of pivot into COVID-19 and sepsis, you've already sort of mentioned that COVID-19 sepsis is simply where the SARS-CoV-2 virus is the infection that tips the body into a septic state.
Yes.
We get a lot of questions about who's most at risk for that sort of severe disease from COVID. So from your perspective and your experience, what would you say to those asking that question?
Yeah, well, from both experience and from the data, what we do know so far, and you've been talking about this for the last year really, is that we know that older people my age and up, sadly, I'm 63, almost 64, people my age and up are at higher risk. Overweight people are at higher risk, and we often say a body mass index above 30, which is what is considered to be obese, but in point of fact, above a body mass index that's normal, sitting at about 23 all the way up. There's a pretty close relationship with higher incidence of infection and worse course of disease when you get it. Diabetes, chronic kidney disease, chronic lung disease, especially emphysema. Asthma, we've been fortunate. We initially thought that asthma would be a really big risk factor, but it has turned out that it's not as big a risk as we think. But emphysema and other forms of chronic bronchitis and chronic obstructive lung disease definitely are high risk factors.
I would like to throw in one more too, unvaccinated status.
Thank
There you go.
High risk.
Thank you for that. Yes.
Yeah, so as it turns out, when you're talking to the pulmonary doc, it's all about the lungs, asthma, emphysema, COPD, and when you talk to the
Breathing,
infectious
all that
disease
stuff.
doc, it's all about vaccines and infections.
Yes, indeed.
But they do intersect here, to be sure. You know, one of the other, I think, important parts about this conversation is talking about treatment of sepsis. And specifically, is it harder or different to treat COVID sepsis versus other forms?
Yes, it absolutely is, and that's one of the things that makes COVID so deadly when people do get critically ill. So the normal mainstays of treating sepsis, run-of-the-mill, we might say sepsis, that's caused by bacteria, which is far and away the most common cause, antibiotics. Early antibiotics, adequate antibiotics that cover the bug that you have are probably the single biggest thing that you can do to treat sepsis. So since all organ dysfunction derives from or is caused by a response to the infection, if you can knock the infection out, the response will often subside. So that's very important. When people have low blood pressure, it's very important that we give them intravenous fluids, and we do that. And then it's basically just support of the individual organs. So if sepsis causes a kidney failure, we will treat potentially with dialysis. If it causes lung failure, we treat with a mechanical ventilator. So in COVID, and actually, interestingly enough, I've written a couple of papers on this and given several lectures internationally about this. COVID is sepsis. COVID that makes it to the ICU, by definition, is always sepsis. And it's just extremely difficult to treat because we don't have really good agents that will knock the infection out.
Yeah, I think the simple way to say that, right, is you mentioned the importance of antibiotics in treating a bacterial infection. Well, there are no antibiotics for this virus. There's no treatment mechanism that stops the infection, and that leads to all the end organ damage that you're talking about.
You have just recapitulated the entire thesis of my papers. Yes.
Wow.
Very nice. I should have asked you. Then we could just.
I often have to translate for the infectious disease
Right.
doctor.
Yeah, I believe that.
I like the bigger words. It helps.
Yes.
I would like to bring on one of the points that you brought up, though. You said every year 350,000 people die from sepsis. That goes along with the point you brought up earlier about the different causes of sepsis and how many different causes, how many different types of bacteria,
Yes.
how many different types of fungus, how many other types of viruses. When you couple that with thinking about 550,000 deaths in the past, 1 year from, say, March to March from COVID
From
alone,
just one
that should
virus.
put things into
Yes.
perspective.
Yep.
And many of those other forms of sepsis haven't gone away.
That's absolutely
Other
correct.
cases.
They have not gone away.
So we know maybe our influenza rate and reduction has had some impact on septic deaths if influenza was the cause, or post-influenza pneumonia causing sepsis. But
Right.
that's been greatly offset. Those 80,000 deaths have been offset by 550,000 COVID deaths.
From COVID. And by the way, since you brought up influenza, this is an important point to get across. When influenza is severe, it causes sepsis. And when you hear of someone dying from a case of influenza, it's because they got sepsis from their influenza. And that's why we need influenza vaccines every single year.
Yeah. And those aren't even as efficacious as the COVID-19
No,
vaccines.
they aren't at all.
But they will help reduce the severity if you do get influenza, for sure.
Absolutely.
One of the other questions that we get specifically as it relates to COVID is there are these long-haul symptoms, right? People have implications long after they leave the hospital.
Yes.
Is that true for sepsis in general?
That is absolutely true for sepsis. In fact, I work as a senior medical advisor for an organization called Sepsis Alliance. And if you guys wouldn't mind, you have their website to put on the screen. It's the sepsis.org. I work as a senior medical advisor for this organization, and we are actually advocating, as we speak, for a separate ICD-9 code for post-sepsis syndrome. Sepsis alters a person's life in so many ways. Mortality risk depends on the hospital you go to, and it depends on the severity of your sepsis. I can tell you that fairly average these days, mortality risk of sepsis, as we define it, is in an average hospital between 10 and 15%, and septic shock mortality is between 25 and 30%. But just getting past it, just getting out of the hospital is the very beginning, because it goes on for months and even years. You're at high risk in your first 30 days. The first 30 days after you get out of the hospital with an episode of sepsis, 30 to 35% of those people will be readmitted to the hospital with another episode of sepsis because of the longer-term effects on their immune system and the weakening of their immune system from having that. And many, many people, especially if you're above the age 65, we just published a series of papers last year looking at the entire CMS Medicare database for every episode of sepsis from 2012 through 2018. And we saw that you have like a 60% chance of being in a nursing facility if you're 65 and above and survive your hospitalization.
You know, Dr. Simpson is being a bit on the humble side when he talks about his role with the Sepsis Alliance or his level of expertise. We truly are very lucky to have an international expert and probably one of the level that you can count, right? There are probably 3 or 4 or 5 in the world with his level of expertise specifically on this topic. And so as we spend so much time talking about the ins and outs and the specifics of sepsis and COVID sepsis, how, from your perspective and in your mind, does COVID sepsis differ from other sepsis? We already talked about the one reason of you can't treat it, but...
Right. There are a couple of features that I'm not going to say that they are different, but they are perhaps enhanced. One of the things we see with COVID sepsis is a very high propensity for forming blood clots, especially in larger sized vessels. Now, all of sepsis, one of the major, what we call pathophysiologic features, which means things that are going on at a cellular or an organ level that are going haywire. All sepsis has clotting in the very tiny vessels, the capillaries in your system. COVID-19 seems to have that in an enhanced version, and the incidence of forming large clots in the vessels of your legs, forming clots in your cerebral vasculature, forming clots in your coronary arteries, forming clots in your lungs, seems to be pronounced over and above what we see in more routine sepsis that we see every year. That is certainly one of the things that's enhanced. In other ways, really, it's the prolonged nature. Quite frankly, with most people in septic shock, if we jump on that with our antibiotics and our fluid resuscitation right away, we can turn that around in 2 or 3 days, unless it's destined to be fatal, which sometimes it is. But we can turn that around in 2, 3, 4, 5 days, something like that. Whereas with COVID, because we can't do that antibiotic intervention or that type of intervention, tends to last. We've had people in the hospital with the sequelae of this for months, literally. And it's not unusual for it to take several weeks to resolve once you become septic and critically ill.
Yeah, and I think your description of the blood clotting was exceptional, and we know that was a problem. I've seen people in the hospital who had very mild disease, but 2 weeks after came in because they couldn't breathe and they had a large blood clot in their lungs.
Exactly.
We've heard of the athletes, the triathletes, or the other young people who wake up in the middle of the night because they can't feel their leg because they have a blood clot in their leg. That was my biggest concern if I did get the disease. We know that the vaccine, there's been questions and concerns about blood clotting. Those are different types of blood clots. Obviously, we know how to evaluate and look for those types of side effects. But the benefit of getting that vaccine significantly reduces your chance of getting those types of blood clots everywhere else in your body as well.
Yeah, good point. And the blood clots that have followed after a vaccine are far, far more rare than the blood clots you got from having an episode of COVID.
Yeah. You mentioned sort of the prolonged implications of this, even in the hospital, 20, 30, 40 days in the hospital. I even know we had one of our early patients that was 220 days.
Exactly.
Yeah.
One of the other hallmarks for me, at least that we saw early on in really severe septic patients with the SARS-CoV-2 virus was this increased rate of renal failure. Renal failure is not uncommon in sepsis, but we had a lot of people needing continuous dialysis for a long time. That seems to be something that may be slightly unusual related to COVID or SARS-CoV-2 as the cause of sepsis as well.
Well, it could be, and this is a fascinating thing here that we don't know the answer to this yet, so please don't take this as an answer. Early on, if we were at risk of running out of anything with the number of people who were coming to our ICUs, it was dialysis machines, because renal failure was so common in our COVID-19 patients. We always had plenty of ventilators, unlike some places in the country, but we were starting to get worried about dialysis machines. Luckily, something changed. Now, purely anecdotally, it's been noted by some of the nephrology doctors that they said when you started using more anticoagulants, it seemed like the dialysis rate went down. And it's purely anecdotal. However, Dr. Mustafa Yunus and I, Mustafa is a hospitalist here at KU, we have pulled the data from our Heron database to be able to examine that question of was there an inflection point when use of anticoagulants went up, and we're in the midst of analyzing that right now, so I'm afraid I have to leave you hanging. As it were.
You know, at least physiologically, it would make sense
Yes,
that fewer small blood clots in the kidneys, which are a very vascular organ, they filter the blood, that would mean less renal failure. And so maybe foreshadowing exactly something you'll find.
Yeah, maybe foreshadowing. Certainly I wouldn't take that to the bank.
You know, in general, you spend a decent amount of your time educating others, physicians, and the public on the signs and symptoms of sepsis and how to identify it early. What message do you think everyone listening or watching today needs to hear around the signs and symptoms and the importance of early identification? Yeah.
First off, early identification and early intervention is key when you have sepsis. The reason that we have such things as, for example, we have alcohol to clean wounds. We have hydrogen peroxide, if that's what you choose to use. If you're a sissy like me, you do the hydrogen peroxide instead of the alcohol. But the reason we have that is to ward off the beginnings of an infection and sepsis to begin with, because it was so deadly. I'm wandering a little bit, but in the era before we had antibiotics, if you got a run-of-the-mill pneumococcal pneumonia, got in your bloodstream, and you were my age or older, your chances of dying were above 90%, which is really fascinating. Which is why it just underscores that antibiotics are so important. So what do you look for? When you get an infection, sometimes the infection you get is going to be around a cut that you get. Sometimes it may be something going on in you that you're really not sure about, like you have intense pain in your belly, in your right upper quadrant, we call this, right up here. It may be a gallbladder that's gotten infected. In the lower part down here, it may be an appendix that's gotten infected. When you feel intense pain, or when you know you've got an infection because you can see it in this cut that you got on yourself, you need to pay attention and you need to get to a doctor early. Now, what kind of things can you do at home that might clue you in? One of the things that sepsis does when you're developing sepsis is it causes you to have a rapid heart rate that's above about 90 beats per minute. If your heart's going faster than it should be going, that's a reason to seek medical attention. If one of your loved ones looks at you and says, "You're breathing kind of fast," even if you haven't noticed it, probably a good reason to seek medical attention if you think that you are infected as a cause of that. And here's something that we have to look out for each other for, because you won't notice it in yourself. I had a very good colleague, one of the top sepsis experts that you alluded to before, who became septic himself, didn't realize it because sepsis alters your mental status, makes you not think as well as you should. But if your family member notices that you are off, if you're not making sense, especially if that's in association with some infection that you already suspected, that's a reason to seek medical attention. So And time is important. It's really important. Fever, obviously, everybody knows fever as a sign of infection. So if you're having fever and these other signs, not every fever needs to come to the hospital. Yeah, I've had influenza before. I have colds from time to time. I get fevers. Everyone gets fevers. It's when you start doing these other things that you have to be concerned.
You know, you talked a lot about cuts, belly pain, pneumonia, all as causes of infection, and that many of those lead to sepsis. There are other things that I think sometimes people think is very simple infections like urinary tract infections that lead to a lot of sepsis, urosepsis itself being one whole cause that we spend a lot of time with. So I think your case that anything that doesn't seem normal that's related to infection can get serious in a hurry, and if you have any of those other symptoms, seek medical attention.
Yes, it can, and some of these bugs can move really, really fast. You know, the so-called flesh-eating bacteria, can move through really fast. Even run-of-the-mill pneumonia. Pneumonia, by the way, is the #1 cause of sepsis. It's the #1 cause of hospitalization for an infection of any kind. And it can be stamped out pretty easily if you get here early. If it festers, can be really difficult to deal with.
But I would like to say that sinusitis we do not see as a large cause of sepsis.
That's true. That is true.
And over 80% of causes of sinusitis are viral, so you probably should not be getting antibiotics for those as well. So just please remember that.
That's true.
We want judicious use of the antibiotics.
That's exactly right. There's a very delicate balance here. We know that bacteria are developing resistance to our antibiotics all the time.
Yep.
We want to preserve those antibiotics because when somebody is septic, when somebody has organ damage from an infection, we want those antibiotics to be there for us. So any smart practitioner of medicine reserves the antibiotics for when they're necessary and not just when they're convenient.
All right. Well, we've been all over the
Yeah.
map so far. Jess, let's get to some questions from the community this morning.
Okay, so Dr. Simpson, you're educating the community today because Vicki says this is scary stuff. She says, why are we not hearing more about this in the news?
Why do we not hear more about sepsis in the news? I think because it's always been with us. Before the advent of penicillin, infection was the single most common cause of death. Everyone died. You got pneumonia. I told you the chances of dying without antibiotics were really tremendous. After Alexander Fleming and a lot of the I don't want to say hoopla, it's not exactly the right word, but it's the one that's coming to me. Everyone believed that, hey, we've conquered infection now. It's all good now. We don't have to worry. But in point of fact, that just turns out not to have been the case. We may have shifted it so that it's even a little more difficult to see because people do get antibiotics so commonly for small little infections. What I see as an advisor to Sepsis Alliance is that over the course of time, there is getting to be more in the news. And I myself have been on the news at various times. It's just that it's not something that people keep at the forefront. I think it's scary myself. I've been telling everyone for years, 350,000 people every year. This needs to be in the news all the time. As a matter of fact, to that end, I took a job working, while I still work here, but I also work a lot of my time for the U.S. Department of Health and Human Services in a program called Solving Sepsis, where we are trying to fix that for the nation. But you're right, it's scary. It's my #1 fear for when I get old.
Susie wants to know the difference between staph infection and sepsis.
Staph infection is Staphylococcus is a type of bacterium that can cause sepsis. People, I think, and doctors, I think, use this because we play into, doctors figure out what worries patients. When we want them to be worried and want them to seek attention, we go, this could be a staph infection, because we think that patients have all heard that staph infections can be bad. What makes them bad is the sepsis from the staph infection. What makes them sometimes worrisome to us is that we know, even in our community in Kansas City, Dana, you probably have more recent numbers, but 10 years ago, half of all the staph infections in our community were caused by organisms, staph, that was resistant to the routine antibiotics. So we have to be on top of it. And that's also what makes staph sort of a bad player, is that if you're not on top of that and give the special antibiotics, you can miss treating it, and getting antibiotics that are ineffective is the same as not getting them at all.
Yeah, sepsis can be caused by a number of different organisms, just as you said. Staph is just one of those organisms. Pneumonia can be caused by a number of different organisms. Bacterial, fungal, viral. It's just a general term for infection of the lungs, but sepsis is a general term for overall body infection and your response to that. But it can be caused by many different things.
Jane wants to know, how do strokes factor in with sepsis? Is there any connection?
Jane, there are two different ways that I can think of that stroke factors with infection, or with sepsis. One is that the overall body blood clotting that we were talking about, and especially in COVID sepsis, can result in clotting in the arteries and veins in your brain and result in stroke. That is one way. Probably the lesser common way of these. The other way that stroke often causes infection is if it alters your swallowing mechanisms, if it alters the ways that we protect ourselves from getting infected. And the ways we do that are cough, gagging, choking. This feels terrible when it happens, but it's happening because you're protecting yourself from aspirating bacteria and other things down into your lungs. So stroke can result in infection this way. And then lastly, stroke often results in a reduction in activity, so that you spend a lot of your time sitting or you spend a lot of your time lying in bed. Both of these things promote infection and development of sepsis.
You mentioned this a little bit earlier, but Isaac is asking, how concerned should I be about getting sepsis from a paper cut? Is it rare, not rare? How possible is this?
It is pretty rare, but it does happen. And that's the thing. Actually, I'm working on a paper right now with a gentleman from Harvard where we are looking at how frequently do people that have no underlying problems at all, perfectly healthy people, how frequently do they get sepsis, and what can we tell about the course of their sepsis? And this is the hard thing about this, is what we know is they're much less likely to get sepsis from a cut, but when they do, they're much more likely to develop really severe illness. So you have to pay attention. And how do you pay attention to a paper cut or some other cut that you get? You watch it, you feel how tender it is and whether the tenderness is getting better with time or getting worse with time. You look at it, you see how red is it around that cut. That redness is your body's response. It's bringing white blood cells in and attacking the bacteria that may have gotten in that cut, and it's making it red and painful. And sepsis, by the way, think about that red and painful being all over your body. That's kind of the way sepsis is. So if that redness is spreading and getting worse, then you need to seek attention. If it's staying the same and gradually going down, you're A-okay. But it's not common, but it can be really bad.
And I think I just tell my children, they've gotten very good at this, if they get a cut or a laceration, anything trauma like that, just wash it with soap and water, pat it dry, make sure it's clean. We know for injuries on the head, that's one of the reasons why the head bleeds so much. It's to help clean out that area of that cut. But just very easy, soap and water, pat it dry, and then watch. Now, obviously, if you're getting a bite by an animal, especially a cat or dog, you probably want to seek some medical attention to get some early antibiotics to prevent infection that way as well.
Right. And let me add, if one of those things happens and you shortly afterwards develop a fever, that likely suggests that you got a pretty good injection of bacteria, and you probably should seek attention now.
And we know that a lot of people, like having their animals lick their wounds or get licked by them, but
Oh, I didn't know that.
yeah, we see it quite frequently. So
Dana's taking us there again. One of the other important considerations, I think, in this question is there are patient-specific factors that matter. So someone who, say, is in the middle of intense chemotherapy for
Yes.
cancer care, or someone who's had a transplant, may have a higher risk of severe infection or sepsis from a cut than someone who's young and has none of those risk factors. And so, in general, the answer is yes. If you have a paper cut, it's not very common. But if in certain circumstances, there may be people that risk is much, much higher. And so, if you are in one of those populations, we do our best to educate you about it, right? If you're in the middle of chemotherapy, we talk about you are at an increased risk of infection. That, of course, then translates to an increased risk of severe infection. And sepsis is the most severe sort of that. So I don't say that to scare people. It simply is a sort of a reminder to not discount the other things going on in your body or in your medical treatment that may have an impact on whether severe infections are more of a risk for you.
That's absolutely well put.
See, there you go.
Can we go back and talk more about kids and sepsis? Jen is just wondering what she should look for
Yes.
in her children, what questions she might need to ask them.
Yes. So first off, I'm going to say I am not a pediatrician. I haven't laid hands on a child since I was a third-year medical student with the intent of treating them. And so I want to say that. Also, some of the signs and symptoms we look for in kids are a little bit different from what we look for in adults. And even what we call a rapid heart rate in an adult is normal for a small kid. So some of these things are different. But the key thing that I think that is missed, not by parents in general, but by doctors a lot of the time is, no, this is going on longer than it should be going on. We are fortunate that kids tend to handle infection better than grown-ups do. And we don't quite understand why that is. We have some thoughts, but don't quite know. But they tend to handle it better. But if the doctor says, no, this is just a stomach ache, and he's just vomiting, and you happen to know that there's some potential source of infection, then you should be persistent. And ask the question. Actually, this is something I like for everyone to say. When you come to your doctor, ask the question, could this be sepsis? I think it's one of the most potent things that a patient can do because I work in an intensive care unit. As I told you, sepsis is responsible for many of the people that are here in my intensive care unit. If I get called to see someone, I first think, is this sepsis? And then I think, okay, let's move past that to something else. But that's not true of your pediatrician who sees whole lots of normal babies every day for well baby checks and well child checks and is not seeing sepsis every day. So for you to bring it up and say, I'm worried this is an infection and I'm worried this is sepsis is an important thing to kind of snap out of the day-to-day well baby stuff into this may be something else. But so what to look for, changes in mental status. If your kid is confused, clearly confused, something's wrong, and you need to pay attention to that. If they have a fever that's unrelenting, you need to pay attention to that. If they have pain, like I said, in some place, say you've got your 11-year-old kid who suddenly has pain down here in their belly that is really intense and they can't move around comfortably, seek attention.
Earlier in my career in a different institution, I actually spent a lot of time in pediatric ICUs and in the pediatric operating rooms. One of the good things in this conversation about our kids, as you said, Dr. Simpson, they tend to handle infection fairly well. And so just thinking about the percentage of those children that are in a pediatric ICU that are there for sepsis is much lower than the percentage of adults that are in an ICU for sepsis. It doesn't mean it can't happen, but things like persistent seizures or persistent asthma or accidents, And then other things like childhood cancers and surgeries are reasons that kids are in the ICU far more often than sepsis. Not impossible, but definitely not the same degree of, or the same number, the same percentage of those kids getting really, really ill and needing to be in the ICU for infections that we see in older populations.
I have a few more questions for Dr. Simpson. We can get
right.
those in. We'll save our COVID questions for Friday. So Mary wants to know, how effective is the pneumonia vaccine protecting you against possible sepsis, since that's a way you could possibly get it?
Yeah, that's a really great question. I'm glad you brought it up. When you hit age 65, you become higher risk for pneumonia with every passing year, and it's recommended by the CDC that you get a pneumonia vaccine when you hit that age group. It is where we can study it in high-risk individuals. The vaccine is highly effective. Apologize for that. It's highly effective at preventing the infection that is pneumococcal pneumonia, the most common kind. It's especially effective at preventing severe complications such as sepsis and septic shock and death from the pneumonia. So it's very important. It should be a part of everyone's general health care when we hit that age. And then also, if you know that you're missing a spleen because of an accident, you should have a pneumococcal vaccine. If you know that your spleen is going to have to come out electively for some reason, get the vaccine first. And then there are probably some more things that Dana can tell us about.
Yeah, absolutely. There are two major pneumonia vaccines that we use. We say pneumonia just as a general term because people understand that. One is Prevnar and one is Pneumovax. Certainly 65, but some people before that age go into those groups where they should receive it and could receive it. And it's extremely effective at preventing invasive disease as well, such as bloodstream infection from the bacteria, as well as meningitis and heart infection from the bacteria. So certainly talk with your providers. Those are other vaccine preventable conditions that we can use Prevnar and Pneumovax to prevent against. So it is very important to talk with your providers about getting them.
Linda just joined us and missed your answer on this, but is toxic shock sepsis?
Toxic shock is sepsis. It is caused by, in general, by specific organisms. And I'll try and tell you what's a little different about these organisms is that they tend to secrete a toxin out into the surrounding body tissue where they are, that toxin can circulate and it can stimulate the septic response in your body. So yes, actually toxic shock syndrome is a sort of specific form of sepsis caused by certain specific bacteria, usually Staphylococcus, actually.
Yeah, and different mechanism, but it's not unlike the overwhelming immune response that we see in some of those severe COVID cases.
Right. Yeah, true.
Okay, Jill asked, do you see that large fluid bolus? Did I say that right?
Bolus.
Do you see that large fluid bolus are still a large part of the initial treatment plan for COVID septic treatment?
When a patient is hypotensive, our first response should be to determine whether they respond to a bolus of fluids. And so large is in the eye of the beholder. We typically say that the bolus that tells us they're not going to be responsive to fluids is 30 milliliters per kilogram of body weight, which would be about 15 cc's, half a teaspoon per pound of body weight is the amount of a fluid bolus that one gets. If they don't respond to that, then fluid boluses should not be continued, because we know that giving too much fluid is not a good thing for anyone in the hospital, and certainly not for COVID patients.
That is a debate that has raged for many, many, many decades. With, I think, the real answer here, right, for people at home is to say, when we talk about hypotension and responsive,
Yep.
if your body says, I like that fluid, and your blood pressure gets better, it's low and it gets better when we give you fluid, then you're fluid responsive and that becomes part of your treatment. But
Yep.
if you don't respond, that's what you mean by not responding,
Right.
then we're not going to give you something that doesn't benefit you.
That's not helping them. Yeah, and I'm going to take the opportunity to say that KU, especially Dr. Heath Latham leading the way on this, is in the absolute forefront of personalizing fluid bolus administration to what's happening with this patient right now. And we published one of the first papers showing that your outcomes are improved if we tailor this to how well your heart responds to a fluid bolus instead of just your blood pressure, which is a little less specific. But I think it's cool that this institution is in the forefront of leading the way on that.
And this is sort of an area that we spend a lot of time in the operating room on as well.
Yeah.
When we look at this individual response, we have a lot of technology that allows us to
Yeah.
do this. So years ago, gosh, it's hard to say that, when I was in residency or early faculty, maybe the only way we had to do that was something really invasive called a Swan-Ganz catheter.
Yes.
And now we have little patches that we
Yes.
can put on your body that we
Exactly.
can measure your individual response, and we
Yes,
can know
exactly.
more fluid, less fluid, are you responding, were you an hour ago but not now, what is changing?
Exactly.
It truly is incredible,
Exactly.
the difference in 15 years.
Yes, it is. It's amazing.
All right, last question is from Patricia. She says, at a very young age, our great-grandson was diagnosed with Kawasaki disease. Would this cause greater concern in watching for infection from cuts and so on?
Boy, you've just dived right out of my area of
Yeah.
expertise. Kawasaki is a disease that's pretty much generally seen in kids. It looks very similar to this thing you probably heard about, cytokine storm, in both kids who have boy, I'm diving right in here, but have multiple organ dysfunctions from COVID. Looks very much like that. Typically, it's treated with drugs that are immunosuppressive.
Yeah.
I don't know how long that immunosuppressive treatment
Yeah.
goes on, and I am so far out of my expertise that I am really sorry to say I can't give you a good answer to your question.
Again, we're not pediatricians. I'm not aware there's any long-standing consequences to that, but I think we will be having some Children's Mercy colleagues on soon, and I can also pose that to some of our
There you
pediatric
go.
colleagues here. And
Yeah. So
Yeah,
stay tuned.
the hospital.
Tune in every day so you can hear the answer when it comes across.
There you go. Yeah, very specific question that I think is a great one to ask, especially as it pertains to the impact of all of this on your particular situation. So we'll do our best to make sure we get you some general direction. As always, though, if you have specific questions, it's very, very important to stay connected to your individual providers who actually have all of the information and can provide you with a specific medical advice for the circumstances at hand. So, great question. Thanks for that. We'll definitely add it to our list of things to get back to you on. As we wrap up today, tomorrow on the program, Dr. Mitchell Douglas, the medical director of our Marillac campus, and our Marillac campus is our pediatric inpatient and outpatient behavioral health campus. Dr. Douglas specializes in inpatient mental health care for patients ranging from maybe 4 years old to 17. We'll be joined by psychologist Dr. Daniel Johnson, and they'll talk about youth and mental health. It's an important conversation because our Marillac campus is actually unable to care for 150 suicidal teens each month because we don't have capacity. We'll talk a lot about how you and the community can help that problem, which is very real. As we wrap up today, Dr. Simpson, any final thoughts?
No, I just want to say thanks for having me. You probably know that my second favorite thing in the world is teaching people about sepsis, and it only comes behind taking care of people who have sepsis and
Yeah.
getting them better.
And we can all attest to that.
Yeah.
We've all been on the receiving end in a very, very good way of very, very important education and expertise as it relates to the topic. So thank you for that.
Yeah, I'd like to
Dana.
thank our guest and our expert and our our great physician and teacher. I think most of our audience is probably ready to sit for the medicine boards now after this primer. So, but just remember, these are things we see every day. We are not trying to cause fear. These are things that we deal with matter-of-factly. We are trying to promote education to protect you and so that you understand things to look for at your home, but also what we deal with every day. Nobody wants to have sepsis. Nobody wants to have COVID sepsis. The way out of that and to protect you not only from sepsis and hospitalization and going to the ICU, but also those long-haul symptoms and the blood clots Dr. Simpson was talking about, was through vaccination. So please, encourage those people in your bubble, encourage those people that you know that have not gotten vaccinated to please get vaccinated. That is the way to protect yourself and your community.
And I'll end on a similar note. We know that in the next days or maybe week, the FDA and the CDC advisory panel on immunization practices will meet again, this time to review the emergency use authorization application for the Pfizer vaccine for those between ages of 12 and 15. That will remain an important part of our response over the next few months. And even some hint that the time frame for applying for an EUA for younger than 12 might be as early as this fall. All good things for those of us who are wondering what the future vaccination looks like for our children who might be in those age groups. So as we prepare for those things, please remember we have plenty of doses for those of you who have not yet received your vaccine. If you have questions about why or why not to receive the vaccine in your specific circumstances, again, your primary care physician or our team would be happy to have those individual conversations with you in a venue and in a way that feels important and that you trust. So if we can be of assistance in any of those things as we continue to encourage and really point out the importance of vaccination, please don't hesitate to let us know. In the meantime, stay safe out there, and we'll see you tomorrow.